We will be starting our debate session next. Could I request Dr. Shashank and Dr. Vikas to come here? They are the judges. And we have Dr. Anupma Bahadur and Dr. Pallavi speaking for and against whether robotic surgery should be used for only complex gynecological surgeries. Dr. Shashank, please. You're the judge, yes.
Can I have my slides? Now we move on to the next session, which is debate. I would like to request judges on stage, Dr. Shashank Shekhar, Professor and Unit Head at AIIMS Jodhpur, and Dr. Bikash Banerjee, Senior Consultant Gynecologist, Lap and Robotic Surgeon at Medica Super Speciality Hospital. And topic for debate, should robot be used only for complex gynecological surgery? And speaker for against Dr. Anupama Bahadur, Professor and Unit Head, Department of Obstetrics and Gynecology, AIIMS Rishikesh.
Thank you, Dr. Ruma, for bringing in this debate. I think we thought about it when we were in Athens, that should we have a debate on whether robotics should be used only for complex gynae surgeries. And I'm very glad to see my friend, Dr. Shashank Shekhar, who's going to be the judge. Okay, sir, don't be biased because you are an oncosurgeon. So I will be speaking in favor of benign surgeries. Now, we all know that MIS has taken over the world with widespread use both in benign as well as malignant pathologies. The benefits, of course, include shorter hospital stay, less blood loss, reduced post-op pain, and superior quality of life with a faster recovery. With this, there has been a rise of robotic surgery, and this has been taken from Intuitive, who announced the fourth quarter earnings in 2022. And with their Intuitive Surgical Sustainability Report 2021, I'm sure the numbers have changed because Arnie gave different numbers. 6,700 Da Vinci surgical systems have been installed all around the globe. I think he said 7,500, with more than 10 million procedures performed. And in India itself, more than 90 Da Vinci surgical systems have been installed and more than 50,000 procedures performed till 2021. The numbers would have gone up by the time we have entered 2023. Now, this has been a study by our own president, Dr. Ruma Sinha, along with Dr. Vanita Jain, Dr. Som Shekhar, who's there with us today. And it was a multi-institutional trends in gynae robotic surgery in India, a real-world scenario. So it was a retrospective analysis published in a PubMed Index journal. They looked at 1,500 cases of robotic-assisted surgery for gynae diseases in 5 tertiary care renowned hospitals in our country between July 2021 and July 2011 to June 2021. So they looked at almost a decade of their personal experience in their field. And as you can see, that they concluded that a burst of adaptability has happened for malignant cases in 2017 and benign cases in 2018, probably due to the increased availability of robotic platforms and improved awareness of technology and training amongst the medical profession. So with the new systems pitching in, more and more number of surgeons are being trained and are adapting to this technology, with the common benign cases being operated upon, including leiomyomas, endometrioma, adenomyosis, wall prolapse, adnexal masses, and abnormal uterine bleeding. And The malignant and pre-malignant diseases are, of course, CI endometrium, endometrial hyperplasia, and CIN. My opponent will be able to define this better. So with this, the advantages of robot, we all know, are higher precision, tremor filtration, ergonomics, 3D stereoscopic vision, intuitive movements, endorist movements, shorter learning curve. So why just restrict it only to malignancies? Why should it not have a platform even in the benign? So coming to our my first answer, it has a shorter learning curve. The learning curve in conventional laparoscopy is definitely much, much higher compared to the robotics, and excellent clinical care. There is less conversion rate once a surgeon gets trained, approximately within 20 to 25 robotic cases required to obtain proficiency using the robotic technique. With a shorter learning curve in robotic surgery, there is less conversion to laparotomy, and more benign cases and early stage malignancies benefit from MIS. Now, there's another study where they looked at the increasing use of robotic-assisted approach for hysterectomy, resulting in decreasing rates of abdominal hysterectomy and traditional laparoscopic hysterectomy. And again, this was a retrospective review of 623 consecutive patients. They divided 311 in the early period and another 312 in the late period. And they found that more and more utilization of the robotic approach to hysterectomy was related with a decreasing trend of his abdominal hysterectomy concurrent with decreasing rate of traditional laparoscopic hysterectomy, as is evident from this graph. Another thing is better ergonomics for the surgeons. So major factor in widespread adoption of robotic surgery over conventional laparoscopy, with particularly usefulness in the long surgical procedures. Robotic has a role. It decreases the work-related musculoskeletal symptoms in surgeons, particularly in obese patients, and is a surgeon-friendly approach without compromising the patient's safety. So again, this was published in JMIG 2020 in AAG and discussed in AAGL, where they looked at the impact of obesity on surgeon ergonomics in robotic and straight stick laparoscopic surgery. They compared the performance of 4 experienced surgeons in performing simple and complex exercises on animal models with low BMI and obese groups via straight stick laparoscopy and robotics, respectively. So what they looked at was the electromyography sensors were used to analyze the surgeon's muscle movements, and they measured time to complete the exercise and the surgeon muscle movement or activity. So they found that the time to complete all exercises was significantly and statistically lower for robotic-assisted surgery as compared to straight-stick laparoscopy. And they even looked at the muscle usage as determined by the EMG peak, which was significantly higher in normal BMI straight-stick laparoscopy and even higher in BMI straight-stick laparoscopy, but was generally flat for all normal and high BMI robotic-assisted surgery exercises. Again, this was statistically significant. So again, the next thing is stepwise learning. Coming from an institute of national importance, it is imperative for us to train the younger generation. So we have to train them with baby steps. We don't go on, to making them do complex procedures first. They have to understand serial graduation from the simple procedures, and then they go on to the complex surgeries. So similarly, it is vital to ensure that if you are going to train them in robotic surgeries, they need to first understand how to go about simple surgeries first before they graduate to complex surgeries and, of course, malignancies as well. So it is vital to ensure safety of handling the robotic platform. We have to ensure patient safety first. Robotic platform, it is now accessible to a wider horizon of gynae surgeries, as I've already shown in the intuitive report, and the learning environment is made easy with the dual console. So in our institute, as well as I think in AIIMS Jodhpur as well, there is a dual console by the Da Vinci Xi surgical system, which has gone on to revolutionize the training atmosphere. And utilizing the dual console, it enables a safe teaching and supervising platform. This was published in 2012 in the Journal of Robotic Surgery. The next thing that one talks about in robotics is that it is high cost. Well, initial negative balance in view of the high installation costs can be worked upon. With increasing expertise, increasing number of cases, the cost gaps are definitely being narrowed, also with more and more competition coming in. Plus, there is decreased post-operative complications. The patients, it's like a daycare surgery, they just go home the same day. So that aids in decreasing overall health expenditure, and it definitely has a role in benign surgeries. And of course, my opponent will talk about the complex one. This is just a cost-benefit graph. So the take-to-work messages are that in academics, we need to train the trainees. They are the leaders for the future. Robotics, it is a high-efficiency tool which should be there in the armamentarium that has already been highlighted by Professor Arnold as well as Dr. Ruma. It is the standard of care and it is here to stay. All of us must realize that this is the investment for the future because of improved clinical outcome. Of course, with high volume of cases and more number of surgeons being trained, it will bring down the cost. It is surgeon-centric, so my question is, do you want to be behind or do you want to stay ahead? Thank you.
I would request the speaker for FIR, Dr. Pallavi Ram, Professor and HOD, Gynae Oncology, Laparoscopy and Robotic Surgeon, Kidwai.
Good afternoon to the August gathering. Good afternoon, respected chairpersons and my dear colleagues. So the topic of debate is today, should all robotic surgery be done for complex surgeries or should it be done for a simpler gynecological surgery? It is not a question whether you do it for benign or malignant. It's a question whether you want to do for all simple gynecological malignancy or only complex gynecological surgeries. So let's see what the literature has to say. I say yes, it has to be done it is more useful when you do it for a complex gynecological surgery, irrespective whether it's benign or malignant. So let's look into the literature, what it has to say. It's something like when you have a new hammer, you tend to see every problem as a nail and you want to use it. So what do you mean by complex surgeries? Since the introduction of robotic, we have been doing more and more complex surgeries has been performed. And till today, we don't know the apt indications for surgeries to be done robotically. When you look at all the RCTs, recommendations or opinions that indicate that robotic surgery is not a condition specific, but it is a complexity specific. So when you think of doing a robotic surgery has no special, when you do it on a simple simple gynec procedures, you see that there is no special advantages in these cases. So how do you define a complex gynec procedures? So there's no definitive definition as such to this, but according to the NICE 2022, it says any complex gynecological procedures are defined as having multiple characteristics, either related to anesthesia or surgical complexity, such as previous abdominal surgery or pelvic surgeries, morbid obesities, large retroperitoneal pelvic masses like fibroids, huge fibroids, broad ligament fibroids, posterior myomectomies, extensive rectovaginal endometriosis, or in case of severe endometriosis where you have a frozen pelvis, patients with high BMI who have who have malignancy like endometrial cancers or huge fibroids. These are the things which is being classified as a complex gynec surgeries. So my dear friend has told you the advantages and disadvantages of robotic surgeries. So when you look at these advantages and things when you weigh, so does one really need these quality or investment for a simple gynecological procedures? Is a question mark. So why should we use this only for complex surgeries? That means where it improves the ability to perform these complex surgeries in view of these robotics have good precise manipulation, or its greater dexterity helps us to perform the surgery successfully without conversion to the open. And when you're doing extensive surgeries like anastomosis, exploration of retroperitoneal space, or when there is an extensive adhesions and you want to do addusolysis, the robotic is much helpful when compared to the conventional laparoscopy. And the suturing techniques becomes much more easier and apt in these cases. So some of the studies have shown when you have a morbid obesity patients, the surgical complications and the hospital stay is decreased in these obese patients, and it is more advantageous to do these complex surgeries robotically. So even most of these studies also show in these obese patients, that is, it is the safest option for morbid obese patients and can facilitate surgery in most challenging patients, avoiding laparotomy or the conversion rate, and the associated morbidity and mortality is reduced in these cases. Again, when it comes to blood loss and the hospital stay, it is shown that robotically it reduces the hospital stay and thing in complex surgeries when compared to the conventional laparoscopy. So as I told you before, it is very useful in extensive endometriosis cases, especially when you have a deep infiltrating endometriosis. This robotic assisted surgeries enables us to do the surgery effectively and reduces the risk of open surgeries or conversion. So it's worthwhile using in such cases. So this is a paper which says that robotic assisted is as good as a conventional laparoscopy, but with a fewer complication rates. So it is well a thing to be used in an extensive laparoscopic endometriosis also. So when it comes to urogynecological cases, it is much more easier to do robotically because you are working in the deep pelvis. So in cases of your sacroplexis, complicated sacroplexis, it is much more easier when you use when you do robotically when compared to laparoscopic surgeries. So it is reported that it's a benefit in terms of access, pain, and stay of length is much better in robotic assisted surgeries. So when you come to malignancy, it is a well-established data is there that it is the safest and the better thing to be doing robotically, especially the CA endometrium cases. So where it does not affect the survival outcomes of these patients. In fact, you can show that several studies have shown that after the introduction of robotic, it has significantly reduced the number of open surgeries in these cases, and therefore the number of complications and overall survival is not affected, and even the cost is reduced in these cases. So what do you mean by simple cases? What do I mean by that's not effective to use in simple cases? Like it is shown that in the, however, when you see that patients with, there is no extra benefit in these simple cases. It does not have any extra benefit for simple gynecological cases when it compared to the conventional laparoscopy, which can be done, these simple cases can be done comfortably even with your laparoscopy also. There are a few studies which says that by doing laparoscopy or robotic in simple cases, it does not, it suggests that surgical complication rates might be comparable in both. It is not increased when you see that. Simple cases like tubular anastomosis, simple myomectomies or simple cystectomies when you look at these things, it is not cost effective, or you don't have the hospital stay or the duration of the surgery doesn't matter in such cases. And in such cases, it is you feel hesitant to promote robotic adaptation for benign hysterectomies due to the concerns of cost until randomized trials show that it is beneficial than the usual conventional laparoscopy. When you look at the recommendation also, they say that case selection should be based on likelihood of improved outcomes compared with other surgical approaches due to the complexity of the cases or the patient factors, which appropriates the consideration to the cost. So there are no randomized RCTs to demonstrate superiority of robotic assisted in a simple cases or instead of non-cancerous cases, I would say simple cases compared with laparoscopy. It also says that patients scheduled for gynecological procedures for short duration or low complexities are likely or very unlikely to be benefited from robotic assisted surgery. Like these tubal ligations, simple ovarian cystectomy, surgical management of tubal ectopic pregnancy, bilateral salpingo-oophorectomy, bilateral salpingectomy, or a diagnostic scopy is not worthwhile doing by robotic. So when you see the SWOT analysis also, it says that though we have more than around 500 trained robotic surgeons in our country, so is it justifiable to generalize the use of robotic to even simple gynecological surgeries is a question mark now. Now, usage may lead to irrational demand by the patients mounting onto undue pressure upon the surgeons as well. Hence, there will be an irrational use of robotic surgery in fear of missing out of not doing it. So don't go overboard with the exotic and complex ways of paint. Stick to simple solutions unless there is a good reason to do it otherwise. Robotic surgery is an intuitive, minimally invasive surgical tool which provides added benefit when undertaking complex procedures. Laparoscopy as a primary minimally invasive surgery should remain the method of choice for simple gynecological procedures. If surgery is perceived to be complex or conversion to laparoscopy, you feel that there is a risk of conversion to laparotomy is there, then robotic surgery should be considered in such cases. The more complex the surgery, the more effective is the robotic technology is likely to be in a skilled hands. Thank you.
Hello. Thank you, both the speakers. Good points, good debate. Before we conclude or before you take a decision or a conclusion, let me take the opinion of the House itself. So many experts are there. Yes. Opinion from the House. Anyone from the back, please tell me whether complex gynecological surgery should be attempted by robotic or simple also. No one has the opinion.
Yeah, it's only complex. I feel in a country like India, we should be doing complex cases and we shouldn't be wasting our resources in simple cases because it costs additionally to the patient. So if we can do it as easy surgery, I don't think we should be using the robo. Though we...
Thank you. That was a very valid point. But coming from a teaching institute and being an academician and a researcher myself, I would like to refute and say that, we are the ones who are going to train the next generation. We are the ones who are going to give this tool into their hands. So we have to ensure that for patient safety, they need to know how to go about it the right way. Even if you look at the program that has been designed, it began with, the master class being in benign hysterectomy, and then we moved on to the complex cases. So one has to take those baby steps, ensure that, they understand that they have a high-end technology in their hands and they have to use it well for patient safety as well as for surgeons' comfort.
See, when it comes to taking baby steps, I agree with that the new youngsters have to learn the technology. But we are talking about minimally invasive surgery, like when you want to do a simple cystectomy. You can train your students to do a simple cystectomy laparoscopically also. And your laparoscopic skills will definitely help you in your robotic skills. It will complement each other. So it is not that you are not going to teach the youngsters the new technology. What I mean to say is you can do a simple cystectomy with laparoscopy, which is more cost effective, and I don't think the time also is a matter over there. In fact, laparoscopically you can do cystectomy much more earlier when you much more short with a shorter duration when compared to a robotic surgery.
So most of the postgraduates that we are sending out, they are appearing for all these SS NEET, super specialty NEET exams, and their main, what they're taking up is either reproductive medicine, fetal medicine, or even gynae oncology. So what we'll do is we'll train them in benign, and then we'll send them to you for the malignancy
No,
cases
I'm not
in
telling you
Kidwai.
cannot use for benign surgeries. You definitely need it for a benign surgeries.
Yeah.
What I mean to say here is for simple surgeries. For simple surgeries, definitely benign.
Definitely
It's not a
doesn't-
question of benign or malignancy. You can use it for benign surgeries, but it has to be a complicated. You can't say I will just do a bilateral salpingo-oophorectomy with robotic surgery. You can't say I will just do a simple cystectomy when you know you can just do it in half an hour with a laparoscopy. See, however fast you're at docking also, it will at least take 5 minutes for you. So with that, with laparoscopy, I think you can finish the surgery by then.
Okay. Can I just make one comment?
And cost.
Can
Cost
I
is the
just
main
make
thing.
Cost,
one comment?
again, it's coming down. I think we'll hear Dr.
If you remember,
Rama.
when we were doing open surgeries, and when I was resident, I used to actually get this information, rather this comment from my own guide, that when we can open the door, why you have to make small windows, enter inside and do the surgery. And laparoscopic surgery at the time when it was introduced. Now, can I ask this question, that how many of the gynecologists sitting here are doing laparoscopic surgery now? So it is the technology. So I think everyone is doing laparoscopic surgery. So it is the technology and it is the advancement of the technology which we have to adopt. There is no question, because we have already started adopting the technology itself.
No, definitely
So
we
it
have
is
to adopt the
advancement.
technology.
So what you are saying again, that will put up a question. If suppose any surgeon is trained in the robot and you are giving small procedures, the person is not able to do the surgery, do you think that there's any advantage of getting the training? That will be another question which will be really answered.
So, ma'am, to just reiterate what you have said, when I think early morning we were having this discussion and I was talking to Dr. Joseph about it. When, the first IVF baby was born in Bourne Hall, the persons who created that first baby, Louis Brown, they went into hiding. Because it was said at that time that they are actually trying to replace God. And today, millions of babies are being born with this technology. So what I would say is that initially, whenever there is something new that comes up, we take time to accept it and we take time to understand what it's all about. And once, we realize what the benefits are, it's like a fish in water. So I think it's very important not to condemn that there is a new technology which is here to stay. In the next 5 years, maybe we will again have this debate and probably take it forward from there.
Yeah.
Me and Dr. Anupama Bahadur got trained in robotic surgery together 5 years back. She has spirited far ahead than me. The reason being because I'm a hardcore laparoscopic surgeon. I think that's the reason Dr. Uma Sinha, when she asked me to judge, she said, you're the most soft person. And the proposition is not doing the robotics, using robotic for simple cases. The proposition over here that we are deliberating is, should we restrict its use to just complex cases? I think I implore all of us to take a more comprehensive view. And gynecology is a dynamic and it's a wide range of diseases. By restricting the use of robotic surgery solely to complex cases, I think we risk losing, giving potential, offering the potential benefits to all spectrum of diseases. I think we should be more inclusive, although the focused utilization is a commendable notion, but I think we should be more inclusive because I believe that innovation thrives when boundaries are pushed and limitations are challenged. So if we restrict the use for just complex cases, as Dr. Adavinkula very emphatically underlined, that how would you, the refinement will come with time. With time, proficient use of technology will be there. So my final conclusion, I think we should be more inclusive and we should not restrict use to just complex cases. That's my case.
Hello. If agreed upon, it should be restricted upon complex. gynae cases. I agree. Then who will do these gynae cases? The experts? The experts are not born. They are made experts of our practice. Who will do these cases? Complex cases? Who will do these cases? The expert surgeon. The expert surgeons will push through. One day he or she was the first day of surgery in her or his first day of surgery. Gradually he or she will push on, carry on and become an expert. So you cannot restrict the use. You cannot restrict use the progress of science or evolution of science. One day there was Hajac or lantern, one day filamentous lamp, next day tube light, next day CFL, next day came LED. Science will go on developing. You cannot challenge it. You cannot restrict it.
It's not a question of restriction, sir. It's just a question
Yes,
of...
it is a question of restriction, my dear.
It's a judicial use of the technology, that's all.
No, so surgeons themselves are quite intelligent, diligent. They know where to stop, where to start, where to begin. So experts are not being born by cesarean section. They practice, they carry on, so they become experts. So who will do the complex surgeries? The robotic surgery. The problem of robotic surgery are two in India, in a scenario of India. Cost and the complex OT operating personnel, etc.
It's mainly the cost.
If you cannot bring the cost, how to bring the cost? The cost will come down by more use. You're giving more number of cases, then the company can't bring it down. So if you want to bring it down, you have to do. I am not bounding. He nicely said, it cannot be boundaried straight. Walls cannot be made. Gradually simple cases, then to complex cases. I think there should not be any fight, but you cannot restrict. Okay. Yes, anyone more? Anyone from the audience? Any comment on the issue?
Good afternoon, everyone. Chota mu badi baat. Madam rightly said that we shouldn't try to be God as surgeons. Very important baseline of our ethics is autonomy. Yes, we can inform our patient of its utilization and benefits in complex cases, but in benign cases as well, benign is the wrong word, in simple cases as well, it's still the patient's right to know that there's an option which could be a little more superior, if not much more superior. Just to cite a small example, if a 20-year-old lady obstetric patient came and asked that she would want to get an NIPT test done, we would not restrict her, but we would be saying, fine, if that's your right to have it done, if you're pregnant and you want to have an NIPT test done. Same thing extends to robotic surgery as well. So they have the right to know and then make an informed decision.
Yes, you are right. That is the way of propagation. Thank you. Yes?
Just one comment. Yeah, actually, very true. Both the people have spoken very well. Only thing is that we have to individualize the cases. Now, we cannot blanket that the salpingo-oophorectomy is a simple surgery. There could be a patient who has had 3 laparotomies before that. In that case, the robotics will definitely help. So we cannot just blanket cases that these are simple cases, the benign cases, they are simple cases. So we have to individualize really. And like she said, for a young patient who wants the best of procedures, why not? It may be just a simple ovarian cystectomy, but she wants a robotic surgery, it's fine. It's a patient's choice always. So we should individualize, and thanks. And I also feel what Sir said, what doctors have said, that you have to learn from the simple cases. You cannot just start with the complex
You cannot
cases.
jump into the
Yes,
expert.
Exactly.
Complex
Very
cases.
good. Thank you.
Yes, someone there. Louder. You have
saying that this is a better option
you
for you.
have spent 2 days in the conference. You tell them the benefits of the robotic surgery. More precision, more flexibility,
Sir,
less hospital stay, go back home early. It's a fantastic surgery.
Yes, sir.
Just go back and enjoy your robotic surgery. What the experts have said, the international faculty has said, there is nothing like robotic surgery. I have gone through 30 years of surgery, open surgery, then a decade of laparoscopic surgery. Now my shoulder has a paining, the backs are paining. I find it so convenient for myself, touch wood. I may hear that I am a selfish guy, but I am sitting and doing the surgery. This is a God's gift to the medical fraternity. It is a friend. The next day, one day you are doing a surgery for 3 to 4 hours. In the evening, go and see the patient. What is the recovery of the patient? And have you ever thought of this vision? Here you can see it from here in the posterior cervical fibroid. The previous night you were sleepless. Tomorrow I have to do it by laparoscopy. Tomorrow I have to do it by open. Posterior fibroid, and go and sit on the console. You see the vision. What is the dimension? You can suture it from this way. You can suture it from this to that way. So there is no comparison. Science will develop. Open to laparoscopy to robotic. How to convince, that is your way of technique, your way of telling the patient. Then you will be benefited. There will be less scar, less adhesion, early recovery. Only remains is the cost in Indian scenario. That has to
Thank
be
you,
taken
sir.
care of. Sir.
You can call it an end. I think in conclusion, as I said, I'm a hardcore laparoscopic surgeon. I'm a friend of Anupama, but despite all my biases, in the conclusion, 2 days of listening to the experts, I believe we should have more comprehensive outlook, and we should have more inclusive approach rather than restricting. Restriction is not good for science and for patient care. And that's my conclusion, sir.
So anything more from the audience? Anything more? Any suggestion from the experts? Anyone more? So let us conclude the session with the permission. Thank you. No fighting. The match is tied. But let us all do robotic surgery.
I would thank judges and speakers for wonderful debate. I would